Welcome to the Deep Dive. We're here to, cut through the noise and get you straight to what really matters. Today, we're diving into a public health issue that's, it's critical, but honestly, quite startling. Child health in India. Just consider this statistic. 46% of children in India are underweight. That's a rate you typically compare to sub-Saharan Africa. Just hint you, right? Yeah. Signals, we're talking about something really profound, deeply woven into society. So our mission for this deep dive is to get beyond those headlines. We've pulled together a whole stack of sources, public health reports, national surveys, detailed medical insights, even tracking how national health programs have evolved. We want to uncover the key insights. Why is child health so complex? What's actually worked? And what still needs serious attention? We're aiming for those aha moments for you, connecting the dots between a child's health and those bigger societal factors. Hopefully, you'll feel really well informed by the end. Okay, diving in, let's look at one of the absolute foundational challenges. Expert, what's a core problem we see impacting young children again and again?
Yeah, if we're talking fundamental challenges, it really has to be protein energy malnutrition, PEM for short. And it's more than just a medical label. It's really a whole spectrum of conditions, and it hits young children the hardest, usually between 1 and 3 years old. Basically, PEM means a lack of both protein and calories, often tangled up with repeated infections. And it's really important to think about this with the tip of the iceberg idea. You see the severe forms like marasmus and kwashiorkor, maybe just 1–2% of cases. But that's just the visible part. It signals this much, much larger hidden problem underneath moderate, milder malnutrition. Estimates suggest maybe 10 borderline cases for every severe one, quietly affecting development.
And the numbers behind this are pretty stark, aren't they?
Oh, absolutely. Globally, back in 2020, over 22% of kids under 5 were stunted, too short for their age. That's chronic malnutrition. And 6.7% were wasted too thin for their height, which points to acute malnutrition. And in India, like you said, that 46% underweight figure, that's massive. The latest National Family Health Survey, NFHS-5 from 2019-21, it backs this up. High levels of both stunting and wasting. And you see differences too. Stunting's higher in rural areas, 37% versus 30% urban, and mother's education, huge factor. Stunting hits 46% of kids whose mothers have no schooling compared to 26% if the mother has 12 or more years. It's a dramatic difference.
Wow.
Yeah. And regionally, you see hotspots. Bihar, highest underweight at 41%. Maharashtra, highest wasting at 26%. So it's definitely not uniform across the country. It's varied and it's deep-rooted.
It's fascinating how interconnected the causes are. It's obviously never just one thing driving PEM, is it? No, so it seems like a real web of factors. Can you kind of break that down?
Exactly. It's that classic public health triangle, agent-host environment. So the agent is pretty straightforward. It's a decrease in the quality and the quantity of food. When kids don't get enough calories overall, their bodies are forced to do something really detrimental. They start burning protein for energy, protein that should be going towards growth, towards development.
Like robbing Peter to pay Paul, essentially.
Precisely. Then you look at the host and environment factors, and the picture gets much broader, much more complex. Maternal malnutrition is a huge starting point. That often leads to low birth weight babies, putting them at a disadvantage right from the start.
Okay.
And there are critical windows in the womb, and then that weaning period when they transition off breast milk. Extremely vulnerable times. Plus, malnourished kids get sick more easily. And when they do get infections, those infections are often more severe.
So it's a vicious cycle.
A vicious cycle, exactly. Illness worsens nutrition. Poor nutrition makes them more susceptible to illness. And layered on top of all that, you have this complex web of socioeconomic issues. Poverty, obviously. Overcrowding, poor housing, limited access to good health care. Then there are cultural factors. Early marriage, having many children close together, illiteracy, low social status for women. These all play a part.
And traditional practices too, right? I remember reading about things like discarding colostrum.
Yes, definitely. Some traditional practices can unfortunately undermine good nutrition. Discarding colostrum, that first milk, which is packed with antibodies because of old beliefs, delaying complementary foods, giving prelacteal feeds like honey or water before breast milk starts. These habits can be really deeply ingrained, sometimes overriding health advice.
And consequences. They must stretch far beyond just being small or sick in childhood.
Oh, absolutely. And often they're permanent. Beyond the immediate risk of death or illness, malnutrition makes children much more vulnerable to infections like measles, TB, severe diarrheas. Think about this. Malnutrition is an underlying cause in about 30% of all deaths in children under 5.
30%? That's staggering.
It really is. It's often this silent killer, not listed as the primary cause, but it's the foundation. And it leads to stunted physical growth, but also impaired mental development. That can be permanent. Lower vitality, reduced productivity later in life, even lower life expectancy. It just underscores how fundamental nutrition is for survival, yes, but also for reaching one's full potential throughout life.
Okay, so faced with such a massive challenge like malnutrition, how do public health systems even start to measure progress? Or figure out where to focus? What are the key tools, the indicators they use?
Right. That's where MCH indicators come in maternal and child health indicators. These are basically variables, measurements that help us track health status, figure out what the needs are, allocate resources effectively, and monitor how well programs are working. They tell us about health services, sure, but also about the broader socioeconomic situation in a community. And among all these indicators, one really stands out as a kind of a universal benchmark. That's the infant mortality rate, or IMR.
Right, the IMR, defined, I believe, as the number of deaths of children under 1 year old per 1,000 live births in a given year. What makes that specific number so critical?
Its importance really can't be overstated. IMR is pretty much universally seen as the single most sensitive indicator of communities' overall health. It reflects living standards, sanitation, nutrition, healthcare access, the whole picture, and specifically the effectiveness of MCH services. It targets the age group with the highest mortality rate. And crucially, it tends to respond relatively quickly to specific health interventions. So it gives you a fairly rapid signal about whether things are moving in the right direction. It's a powerful snapshot.
That drop in India's IMR from 204 way back in the early 1900s down to 28 in 2020, that's undeniably huge progress. But expert, knowing India's scale and complexity, what are some of the big structural reasons why closing that final gap, getting down to levels seen in developed countries, is still such a tough fight?
Well, while that 28 is progress, context is key, right? Developed nations are typically seeing IMRs between, say, 3 and 7 per 1,000. So 28 is still significantly higher. The world average in 2020 was around 27, so India is just about there. South Asia's average was 35, so India's doing better than the regional average. But still, there's that gap compared to high-income countries.
Okay.
But what the national average hides is the huge variation within India. That's really the critical point here. The 2020 data shows these stark contrasts. You've got states like Madhya Pradesh with an IMR of 43.
43?
Yeah. And Chhattisgarh, Uttar Pradesh, both around 38. These areas form a kind of critical high mortality belt. But then you look at Kerala, its IMR is just 6. 6. That's comparable to many Western European countries. A remarkable success.
A tiny difference.
Isn't it? And Maharashtra at 16, Tamil Nadu at 13, also doing relatively well. So this huge disparity just screams that local context, state-level governance, targeted health initiatives, they matter immensely. It's not one single India story. It's many different stories playing out.
So if IMR tells us what's happening at the scale of infant deaths, the really crucial next step is understanding why. What are those underlying reasons from, the biology of birth right through to the social environment?
Exactly. And biologically, birth weight is, hands down, the single most important factor determining survival and health in that first year. Babies under 2.5 kilos are low birth weight, LBW, and those under 1 kilo. Without intensive care, their chances are, sadly, very slim. And a major driver of LBW, poor maternal nutrition, it often starts before the baby's even born.
Makes sense.
Other biological factors matter too. Mothers aged teens under 20 face higher risks. Their bodies might not be fully ready. And women over 35 also see increased risks. Then there's high parity, having had many previous births, and short spacing between births, less than 2 years.
Why is short spacing such a risk?
Well, it can deplete the mother's nutritional reserves, and it makes it harder to provide adequate care for multiple very young children. It stretches resources thin, basically, affects infant health directly. Multiple births, like twins, also raise the risk, often because they tend to be lower birth weight. And just larger family size can dilute the care each child receives.
Okay. And what about the immediate medical causes of death? You mentioned they change as the baby gets a bit older.
That's right. There's a definite shift. In the neonatal period, the first 28 days low birth weight is linked to almost half the deaths. It's the dominant factor, often stemming from maternal health issues. The other major causes are problems right around the time of birth. Birth asphyxia, trauma during delivery, that's about 13%, and early infections, serious ones like pneumonia, sepsis. Congenital anomalies also contribute. And remember, the highest risk is actually in the very first week, often tied to problems during pregnancy or delivery.
Okay, so that's the immediate newborn phase. What happens after that first month?
After 28 days in the postneonatal period up to 1 year, the picture changes quite dramatically. Now, the main killers are infectious diseases, often preventable ones. Diarrheal diseases are huge. Acute respiratory infections like pneumonia, other communicable diseases too, like measles. And crucially, malnutrition is almost always an underlying factor, making these infections much deadlier.
Right.
And here's a really tragic point. Often, female infants die more frequently during this postneonatal period.
Why is that?
It often points towards parental neglect, sadly, a reflection of societal biases rather than purely biological vulnerability. It's a stark reminder of those deeper social issues.
That definitely raises the question. Beyond the immediate medical and biological issues, what are those deeper societal currents, the economic and cultural factors that feed into these outcomes?
Yeah, the socioeconomic piece is huge. Low income, poverty, the massive drivers of IMR. Mortality rates are almost always higher in slums, lower in wealthier areas. Why? Because poverty often means poor living conditions, inadequate sanitation, malnutrition, less access to quality health care, maybe parents working long hours with less time for childcare. And in India, remember, a significant chunk of the population, maybe around 22%, which was 270 million people back in 2011-12 live, below the poverty line. That's a vast number facing these heightened risks.
Okay, and the cultural and social factors.
Several things come into play. Breastfeeding practices, for instance. Early weaning or using bottles in unhygienic conditions dramatically increases the risk compared to exclusive breastfeeding. Early marriage is another one. It leads to teenage pregnancies. These young mothers are often physically and emotionally not fully mature, which increases risks for both mother and baby, leading to higher infant mortality.
And you mentioned son preference earlier.
Yes, tragically, in many areas, a preference for sons can lead to neglect of daughters.
Yeah.
This is particularly visible in that post-neonatal period where, as we said, female mortality can be higher.
So incredibly sad.
It is. Then there's maternal education. This is consistently shown to be a critical factor. Educated mothers generally marry later, are more likely to use family planning, understand nutrition better, and crucially, they're better equipped to navigate and use health services effectively for themselves and their kids. And we touched on harmful traditional practices, discarding colostrum, using unsafe substances on the umbilical cord, faulty feeding ideas, sometimes a deep distrust of modern medicine. And finally, the quality of healthcare itself is a factor. Lack of good prenatal care, especially in rural areas. A high number of births still attended by untrained traditional birth attendants or dais. All these contribute.
Wow. It's such a complex web. So, faced with all of this, what kind of health architecture has India actually built to try and tackle these problems? It sounds like it's been quite an evolution towards more integrated care.
It really has been an evolution. MCH care, maternal and child health, is defined pretty broadly. Promoting health, preventing illness, treating it, and rehabilitation for mothers and kids up to age 14. And that group, mothers and children, they make up a huge proportion of India's population, about 57.5%. And because they're more vulnerable, they are major users of health services. The aims are clear. Better maternal health, healthy babies, identifying high-risk pregnancies early, cutting down illness and death rates for both mothers and infants, promoting family planning, educating parents on childcare, ultimately aiming for lifelong health.
And this approach didn't just appear overnight, right? It's been built up over decades, with some significant shifts in strategy along the way.
That's absolutely right. It's a long history. You had the National Family Planning Program starting way back in '52, then things like the Child Survival and Safe Motherhood Program, CSSM, in the '90s, the Reproductive and Child Health Program, RCH, the National Rural Health Mission, NRHM, in 2005. But the really big recent shift is the RMNCAH plus N strategy from 2018.
RMNCAH plus N. That's quite a mouthful.
Yeah.
What does the plus N signify?
Right, so it stands for reproductive, maternal, newborn, child, and adolescent health, plus nutrition. That plus N is critical. It represents a major paradigm shift. Instead of looking at maternal health, newborn health, child health as separate buckets, it emphasizes a continuum of care.
Continuum of care.
Meaning providing linked care across different life stages, right? From preconception through pregnancy, birth, childhood, and even into adolescence. And crucially, integrating nutrition support throughout. The idea is that health or vulnerability at one stage directly impacts the next. So you need this seamless support system to prevent problems cascading. It's about integration, not silos.
That's a really ambitious vision, connecting all those dots. For you, looking at this whole range of strategies, what's the biggest takeaway? It seems incredibly comprehensive.
It is incredibly comprehensive. Perhaps the biggest takeaway is that while it's ambitious, managing such a complex ecosystem effectively is the real challenge. How do you make sure all these different parts work together seamlessly on the ground? Because translating these broad strategies into action involves this huge, almost dizzying array of specific programs and interventions.
Okay, like what are some key examples?
Well, one of the cornerstones, and one of the oldest, is ICDS Integrated Child Development Services from 1975. It's actually one of the world's largest programs for early childhood development. The goal is holistic child development, physical, psychological, social, improving nutrition and health for kids under 6, reducing mortality, illness, malnutrition, school dropout rates, and it delivers 6 key services right in the community through Anganwadi centers. Things like supplementary food, immunizations, basic health checkups, referral services if needed, health and nutrition education for mothers, and even non-formal preschool activities.
So really community-based.
Very much so. And it's shown significant impact, especially on child survival and tackling severe malnutrition by bringing services to the doorstep. Then, more recently, you have IMNCI, the India Newborn Action Plan from 2014. This one has really specific, ambitious targets. Single-digit neonatal mortality rate by 2030 and single-digit stillbirth rate by 2030.
Wow, single digits, that's a big goal.
Huge goals. And INP lays out 6 big intervention packages to get there, covering everything from preconception care like iron supplements, rubella shots, through care during labor and birth skilled attendance, delayed cord clamping, immediate newborn care like drying, warmth resuscitation if needed, then care for healthy newborns like home visits by ASHE workers, immunizations, and specialized care for small and sick newborns, things like kangaroo mother care for low birth weight babies, setting up special newborn care units, SNCUs. It even includes care beyond survival newborn screening for certain conditions, and linking with RBSK, which is the Rashtriya Bal Swasthya Karyakram.
RBSK.
RBSK is a program for screening children from birth up to 18 years for what they call the 4Ds: defects at birth, diseases, deficiencies, and developmental delays, including disabilities, early identification and intervention.
That's an incredible scope, from community support right up to highly specialized hospital care.
It is. And there's more. There's IMNCI Integrated Management of Neonatal and Childhood Illnesses. This is a UNICEF strategy that India adapted, adding the N for neonatal to cover the first week of life specifically. It basically gives health workers clear guidelines to manage common childhood killers together: diarrhea, pneumonia, malaria, measles, plus underlying malnutrition. It's cost-effective and focuses on prevention, too. And we absolutely have to mention BFHI, the Baby Friendly Hospital Initiative from 1993.
Ah, yes, focusing on breastfeeding.
Exactly. A global UNICEF program promoting and supporting breastfeeding in hospitals. It has those famous 10 steps to successful breastfeeding. Things like immediate skin-to-skin contact after birth, helping mothers initiate breastfeeding within the first hour, no other food or drink unless medically necessary, letting mother and baby stay together, rooming in.
And that's backed by law in India, isn't it?
Yes, strongly supported by laws like the Infant Milk Substitutes Act of 1992, which restricts the marketing of formula in bottles to protect breastfeeding. And layered on top of all this, you have other key schemes like Janani Suraksha Yojana, JSY, giving cash incentives for women to deliver in hospitals.
Right.
Janani Shishu Suraksha Karyakram, JSSK, offering completely free delivery, C-sections, and care for mother and baby in public facilities. Mission Indradhanush, focusing on boosting immunization coverage, and RBSK screening we mentioned. It's this massive, multi-pronged effort.
It really is.
Yeah.
And sometimes, amidst all that complexity, the simplest solutions are the most powerful. Let's maybe focus on one of those fundamentals. Breastfeeding. Why is it considered the absolute gold standard?
The benefits are just immense, really unparalleled for both the baby and the mother. For the baby, first off, it's perfectly safe, clean, hygienic, always available free and at the right temperature. Can't beat that.
True.
Nutritionally, it's complete food for the first 6 months. It's got higher levels of certain important micronutrients like copper, selenium, cobalt compared to cow's milk, and the calcium-phosphorus ratio is ideal for absorption.
Okay, so nutrition is perfect. What else?
The immunological protection is incredible. Breast milk is packed with living cells like macrophages, antibodies like IgA, enzymes like lysozyme. These actively protect the baby against common infections, especially diarrheal diseases, serious gut infections like necrotizing enterocolitis, and respiratory infections. These are major killers of young children.
So it's like their first vaccine almost.
In a way, yes, it's dynamic protection. Plus, it's easily digested, it fosters that crucial emotional bond between mother and baby, helps with jaw and teeth development. There's even evidence it helps prevent obesity later in childhood. And the stats are stark. In developing countries, babies who aren't breastfed have a 5 to 10 times higher risk of dying in infancy.
5 to 10 times higher, that's huge.
It's massive. There are other benefits too. Helps prevent low calcium levels in newborns. It naturally helps space pregnancies by delaying the return of the mother's fertility. And this one's fascinating. Certain fatty acids in breast milk are linked to better brain development. Some studies suggest breastfed babies might score up to 8 points higher on IQ tests later.
Really, 8 points.
It's debated how much is causal, but the association is there. So the global advice is crystal clear. Start breastfeeding within the first hour, exclusively for the first 6 months, and then continue alongside complementary foods for 2 years or even longer.
Okay, so breastfeeding is fundamental for what the child gets. But connecting this to the bigger picture, how do we know if a child is actually thriving? How do we track their growth? You mentioned a simple tool earlier.
Yes, the growth chart, sometimes called the Road to Health chart. It's a brilliant piece of simple, low-cost technology. Absolutely vital for monitoring how a child is growing and catching malnutrition early. It was developed by Dr. David Morley using WHO expected weight for age data.
How does it work?
The concept is beautifully simple. You weigh the child regularly, ideally every month, and plot that weight on the chart. The chart has lines showing the expected growth path, so you can literally see the child's growth trajectory. Is it going upwards steadily? Is it flattening out? Or, worryingly, is it dipping down?
So it's a visual tracker.
Exactly. It makes growth, or lack of growth, visible. This allows health workers, even mothers themselves if they're trained, to spot problems early. When a child isn't gaining enough weight or shows signs of faltering growth, this means they can get special attention, extra feeding, medical checks, whatever is needed before severe malnutrition sets in. It shifts the focus from just treating severe cases to prevention and early intervention. It's incredibly empowering.
And is there a specific version used in India?
Yes, the Indian Academy of Pediatrics, IAP, has developed standard growth charts suitable for Indian children. They consider a child's growth normal if their weight stays above 80% of the expected international standard, acknowledging that, on average, Indian children might have a slightly different genetic growth potential than, say, American children used in the original NCHS reference. But the principle is the same. Track the direction of growth. Is the child following their road? These charts aren't just about diagnosing. They're about guiding action, getting kids back on track. A testament to how simple tools can have a massive public health impact.
So we've really taken a deep dive today. We've looked at that complex interplay between malnutrition, infant mortality, the huge role of socioeconomic factors, and then India's really comprehensive and constantly evolving public health response. We've definitely seen that shift, haven't we? From those older single-issue programs towards more integrated approaches like that IMNCI plus and continuum of care idea, trying to connect all the dots from before birth right through adolescence. Understanding these intricate connections hopefully empowers you, our listener, to really appreciate just how holistic health is and the sheer scale of effort involved in trying to improve outcomes for the most vulnerable members of society. But as we've seen, while India's made huge strides, those deep-seated challenges, maternal education levels, persistent poverty, certain cultural practices, they still pose significant hurdles. So considering everything we've touched on today, here's a final thought for you to ponder. If you had to pick just one area, one single aspect, where more focused attention and maybe new innovation could unlock the biggest breakthroughs in child health in India next decade, what would that area be? Something to think about.